Namaste everybody. Today I'm going to talk about a very less studied and less talked topic, but seems very appealing to me is the meniscal substitute and how I use hamstring to substitute the meniscus. At the very outset, I'd like to disclose by saying that I work in a resource deprived environment where all the state of the art facilities are not available. And this presentation expresses my personal experience, and very few scientific evidence are available till date to justify hamstring as a meniscal substitute. We all know that meniscal repair is the process that we all do for various type of meniscal tear, but meniscal repair is not possible all the time, especially when there is no meniscal tissue to repair, when the patient presents very late, and a very complex tear. We have come all the way from the Smiley's era when he said that probably even if suspected the meniscal tear, it has to be removed. And now we are in 2022 when we are talking about save all the meniscus. And probably the future of this save the meniscus is if you cannot save, replace or substitute. That is what going to be the future of the meniscal procedure. So how to save or how to replace the meniscus? There are basically three ways by which you can do: the scaffold substitute, the synthetic implant, and the most talked and studied is mat. So scaffold substitute are very popular ones and very promising. Its technique and the versatile to use, but these are very costly, not available in our part of the world, and probably that is the reason why it is not suitable. Very recently, this paper was published when a synthetic polymer meniscal implant was used for meniscal loss. And again, this is in the study period, only one paper so far published. It is costly, it is not available, and again, it is not suitable to our context. Meniscus allograft transplant is by far the most popular and most studied and most established procedure for very much indicated patient. It has a long-term follow-up results and the outcomes are very much promising. But unfortunately, as of now, this is again a very costly procedure. It is not available in our part of the world in all places. That's why it is not feasible. Then what we are left with? We are left with a promising but less study concept is a autologous meniscus substitute. So autologous meniscus substitute is not new. If you go to literature, you'll find out that the history of autologous substitute goes back to 1993 when Kohn published his paper in KSSTA when he replaced or substituted meniscus with the quadriceps in 20 patients, had a minimum 12 months of follow-up, and he explained a very good result. But a paper in 2000 by Fijin Jr., in which this was an experimental pilot study in 5 patients, where in 4 cases same-ET was used, and in 1 case patellar tendon was used, but the results were poor. And the cause of their poor result was the technical issues, because they used to anchor this graft into the soft tissue, not in the bony anchorage. There was no bony anchorage. And then they placed in patient who already have a severe osteoarthritis of grade 3 and above. And finally, the mean age of their patient was 41, which is, to my liking, is quite late. So they had basically the technical issues in failure. This is a paper published in Arthroscopy Technique in 2020, where peroneus longus tendon were used for the lateral meniscus. But this is just a technique which was published, but there was no clinical result of this patient. And the most popular and most encouraging paper that comes in 2022 in KSSTA, where they have used 7 patients and with minimum of 12 months follow-up, and they used hamstring in various of its modality and did a meniscal replacement, and they say that the results were very promising. The hamstring incorporates very well, and then it reshapes into the meniscus, causing or preparing a new meniscus. So probably in our part of the world, in my country, in my place where I work, the only option available for some selected patient is the autologous semi-T transplant. So this is the basic technique in which you harvest the graft and apply a whip stitch on the both the side and put into the back table. Similar to mat, make 2 tunnels, one for the anterior and posterior root, and by various maneuver pull the posterior graft first into the posterior tunnel, then into the anterior tunnel, then use a centralizing suture, and then stitch the meniscus to the periphery. This is the basic principle of the meniscal repair. So this is a small video which is elaborating the surgical technique. So harvest the graft. It is important to apply a centralizing suture and mark the surface that is going to be on the top. Prepare the posterior tunnel. So this is the posterior root tunnel, and put a whatever suture you want. Then you prepare the anterior root tunnel. I always do by outside in technique because since I do not have all the facilities of doing all inside. Then once both the tunnels are prepared and suture are placed, use those sutures to shuttle the graft first into the posterior tunnel. So here it goes into the posterior tunnel, and use the other suture to pull that into the anterior tunnel. So this is we are pulling into the anterior tunnel. So once you pull this, whole of your hamstring is in the joint. Then use the suture which is been applied into the central part so that you can pull, or first suture should be the centralizing suture. And then after that, based upon your choice, you can fix it. You can fix the graft into the place. And then this is how it goes and sets into them. So let me talk about a very interesting case of a 17-year-old boy, a 4-year history of football, diagnosed as ACL tear 4 years ago, but managed conservatively because of the preserved physis. So the patient presented to us after 4 years of injury, and when we did his MRI, you could see that in the mid substance of the MRI, there is in the middle cut of the MRI, there is no meniscus available. So this is the arthroscopy. The patient had a chronic ACL tear, and when you go into the medial compartment, you'll find out that practically there is no meniscus left to repair, but however there is a little bit of peripheral rim. So since this is a 19-year-old boy, we decided to repair his substitute, put more collagen into the meniscus. So this is the posterior tunnel for the posterior root. So we have to be very careful because this is very close to the PCL while making this one. So this is posterior. Then we mark anterior. Since in this case we had to do both ACL reconstruction and the root and the meniscal repair, and I use the same tunnel for the ACL and the anterior root. So the tunnel was made, then the femoral tunnel was made, and the measurement of the standard procedure of ACL reconstruction was done, and then a suture is passed into the proximal femoral tunnel. Then we start preparing the meniscus. You could see that there was just a peripheral rim available. Peripheral rim of the meniscus was present. First I pass a loop of suture into the center, then I pull that suture from the posterior tunnel through the loop, and then I pass the hamstring graft into the posterior tunnel. So once it has gone into the posterior tunnel and then the centralizing suture is visible, then I use the loop which I put earlier into the meniscus to shuttle this suture of the centralizing suture. So this is the first one that goes, and then the inferior one. I use the same suture which has been looped. So once the centralization suture goes, then it becomes a little easy. Your assistant has to hold that suture all the time when you are doing a repair. So there are various techniques by which you can repair all inside in the most of the posterior root, and then inside out and the outside in. So I am very fond of the outside in technique, and it based upon whatever technique you have, you start repairing the meniscus. This is how I do the posterior most outside in repair or at the root. So first you pass suture into the substance of the graft, and then you shuttle that from superior and inferior so that it goes and sits. So if you need some beyond that, probably you have to use all inside. Then you take the graft, ACL graft first. So you pull the ACL graft. You can see that your suture of the root is anterior to the graft. So first you pull the graft, flip the button into the femoral tunnel. So this is the adjustable loop I have used in this particular case. Then pull the graft, and you can see that your proline is anterior to the graft, so that your root goes anterior to the ACL. And then at the outside, you fix that over the bone bridge. So to conclude my presentation, I'd like to conclude by saying that we all value the importance of meniscus, especially in young adults. Meniscal repair is not possible all the time. In that cases, in very selected indicated cases, we have to think about other substitutes. Meniscus allograft transplant is a choice of treatment for many of the cases, and this is the most studied one, but may have issues with availability in the cost. And autologous graft are easily available, but evidence for its regular use is not there. Thank you very much.